We're here with Sarah Wakeman. Sarah, you're from Fertility Associates.
That's right.
Yeah, great. It's really good that you to come in today because I had some really pressing questions I wanted to ask.
Sure.
I'm thinking from a GP's perspective, if an infertile couple came in, what would be some things that a GP should be looking at? Let's start with the man first.
Well, yes, it's always, it is important to see both members of the couple because the man is just as important as the woman, and if there's a problem, it's just as likely that it may be with the man as the woman. So for the man, for both of them, it's important to ask some questions. For the man, things about his general health, obviously, because sometimes if they're unwell with other things, that can impact on their fertility. Any medications that they're taking, because there are some things, particularly if someone's taking medication for hair loss or testosterone for some reason, that can actually suppress sperm production, so that's really important. It's really important to ask about how often the couple's having sexual intercourse, and particularly as to whether there's any problems. If there's problems with erectile function, the man's often not particularly forthcoming about that, so if you don't ask often you won't find out. It's important to ask whether the man's fathered any other pregnancies, and whether there was any delay and what happened with those pregnancies, and then the usual lifestyle type things about smoking, alcohol use, any other use of any other drugs, any family history, because when a couple is thinking about having a baby, if there's a family history of any genetic conditions, that can be important. Sometimes that needs further investigation, and sometimes they could do IVF treatment, and embryos could be tested for serious genetic conditions as well.
And when the man does come to the GP clinic, investigation-wise, are we giving a sperm sample, is it?
Yes, that would be the main thing. He's not going to do it there and then at the GP, but you'd usually send him away with a request form to do a semen sample, and that will normally go to the local community lab, but it is important to know where to take it to, because they often can't just take it to where you'd have a blood test done. They usually need to take it to the main laboratory where it's actually going to be analysed, and usually we'd say within an hour of it being produced. So that can cause a bit of stress for people depending on where they live.
So don't leave it in the back of the truck or something
no,
like that.
and keep it, the best thing to tell people is just to pop it in their pocket, in their shirt pocket or in their trouser pocket, so that it's next to their body that's warm, but on the other hand, you don't want it getting really cold, you also don't want to overheat it, and it's best to have abstained for sort of 2 to 3 days beforehand, but not longer than that.
Right, okay, that's quite useful. And what about from the female side of it? What would you be looking for in there?
Well, for the woman, again, history is important, so obviously how long the couple have been trying to get pregnant for and how often they've been having intercourse, how regular her cycle is, whether she's had any particular problems in the past, with her pelvis at all, the usual medical things.
You're talking about like endometriosis or things
yes,
like
exactly.
that.
If a woman's known to have a condition like that, then there is probably a greater chance that she might have trouble getting pregnant and might require earlier referral, so some further information about that. The usual things about family history and medications, smoking, alcohol, caffeine intake. It's important to advise the woman that all of those things will have a negative impact on the chance of getting pregnant. It's very important to know about her weight as well. Her body mass index, yes, because a number of women may need to lose some weight, and there may be some at the other end who need to increase their weight. We also see a group of women who over-exercise and who probably need to cut back on exercise to allow themselves to get pregnant.
Right, so quite a fine balance.
It is, yes, it can definitely be for some people.
And in terms of investigations for females, we need to do some at day 3?
So traditionally we've set a day 3 blood test where the estrogen level and FSH, follicle stimulating hormone levels, measured. These days really that's probably being surpassed by an anti-Müllerian hormone level, but if they're being referred for public funded treatment, it will still be expected that they have a day 3 FSH hormone level, measure levelled. It's a good chance to do, we'd always check their thyroid stimulating hormone level. It's a good chance just to check on their thyroid function, and then routine pre-pregnancy blood tests, so the same as an early pregnancy, checking that they're immune to rubella, that they don't have hepatitis B, C or HIV. Those things should be checked off.
Okay, and tell me more about the anti-Müllerian hormone, or the AMH.
So that's an important hormone level that we've had available probably for the last 5 to 10 years. The testing's become more accurate over that time, and what that measures, it's a hormone produced by the very small follicles or immature eggs in the ovaries, and the level is a reflection of the number of eggs that are left in a woman's ovaries. So a woman with polycystic ovary syndrome with lots of eggs will have a much higher level. Women with very low levels are women who have less eggs left, are likely to go through the menopause early, and are likely to have a shorter window of time in which they can get pregnant. So knowing that level is certainly useful to give an idea of the woman's fertility, particularly over a longer period of time.
Okay. And you mentioned before about PCOS, and that's an area that's currently of debate in terms of its definition and things.
Yes, so there's been a number of sets of diagnostic criteria, and a number of women are labelled with polycystic ovary syndrome just because they have an ultrasound scan showing what we call polycystic appearing ovaries. There's even debate now about that because, of course, ultrasound scanning's got more accurate. You can see the little follicles more easily. So, we've always said 12 or more small follicles in an ovary. But really, if you scan teenage girls, 70% of them will have ovaries that appear like that. But really, to say somebody has polycystic ovary syndrome, they need other features as well, such as hyperandrogenism, so evidence of a lot of acne or hirsutism or a high testosterone level in the blood, and also quite irregular periods, so either extremely frequent or cycles that are more than 35 days in length.
Okay. And so from what I'm hearing, it'd be quite difficult to diagnose someone at a young age with PCOS because they may have their acne from, say, their parents had quite bad acne, or they've got perfectly good healthy ovaries, but the scan is showing that.
Yes, absolutely. So the recommendation is for teenagers in particular that they need all three of those things. So ovaries that appear like that on scan, the infrequent periods with evidence of not ovulating at all regularly, and the actual higher testosterone level in the blood, not just acne, because obviously acne is common in teenagers.
Okay. And one of the interesting points that I've learnt from this conference is they were talking about unexplained infertility, that couples need to have about 4 or 5 years of trying before they can qualify for the government funding.
Yes, so that's one of our difficult areas. So, people can be seen for a public funded assessment more easily than that, but to actually get on the public funded waiting list for treatment, you need a score done by a fertility specialist, just in the same way that people get a score for surgical procedures. And if a couple's infertility does remain completely unexplained with no other things that we could give them points for, at this stage they do have to get to 5 years of trying, which is obviously a very long time. And if the woman's older than 35 or 36 when they present, then a lot of them are not actually going to get that 5 years of trying and get on the waiting list before the woman turns 40. So it's definitely a problem.
Okay. Sarah, thank you so much for coming in.
Thank you.
It's been a real pleasure to talk to you today, clearing up some of those things I didn't know about infertility. And I think it'll be a great help to GPs with the stuff that you've explained today.
Thank you very much.